All right, people, let's settle down. Dum dum dum. Right. God, you're in for a treat today, aren't you? You've got like loads of really cool people. Our next session is with Roy Lilly, who some of you may have come across. You don't pull your punches, do you, Roy? You just
I try not to. No, I try not to.
you just say it as it is.
Actually, you've caught me for a bad day in my voice. I don't know what's happened to my voice today. I don't know if there's any doctors here, but are there any doctors here? Put your hand up if you're a doctor.
You need a pharmacist.
No wonder you can never get an appointment. They're always pissing about here at conferences.
And he's already made fun of me because earlier I tried to climb up onto the stage.
He fell over.
And I fell down and could have hurt myself. But it's not something to laugh at, Roy. No? I'm not here for your entertainment. Right, and we've got Richard Meddings, we're really lucky to have him, who is the chair of the NHS and worked for Her Majesty's Treasury and worked on the boards of a variety of banks. So a real commercial corporate background, which actually I think the NHS could welcome. Over to you, sir.
Thank you very much. And there's nothing like a good introduction, and that was nothing like a good introduction. So give him a round of applause. He's not had a good day.
That'd be good.
He's had a bad day. He fell over and looked like a sack of shit this morning. And he's not got over it. I thought I won't ring for an ambulance because I'm busy on Tuesday. Yeah. Listen, I think that sometimes, God pays you back. And some people have done something really bad in a previous life to end up the chair of NHS England just after COVID, just as the shit was hitting the fan for just about everything. And then we've in your time, I think we've had 17 Secretaries of State for Health. And now we've got this lot. So welcome, Richard, you're welcome.
Thank you.
Very nice to see you, and thank you very much for giving up your time to talk to us today. Most of us here are pretty fed up with the NHS, I think. So why don't we talk about cricket and England's prospects in New Zealand?
Well, we've just done very well, haven't we, I think? Won very convincingly.
Got any cricket fans here?
Almost as many doctors, actually. But
they did well, didn't they?
Very well, and a young team in
Bazball.
transition.
You like Bazball? What do you think of Bazball?
Well, it's a new technology, isn't it? A new methodology of playing. When it works well, and when it doesn't, it's terrible.
A bit like the NHS.
I wouldn't go quite that far, I think.
You got me into this. So, Richard, you came from a corporate background. You didn't give up easily to take this job. I know you thought about it long and hard before you did it. We've only got half an hour, but just quickly, just take me back to that first week. What was it like to sit in the chair and think, what did you think?
Well, I have got lots of sort of corporate, large PLC experience. I've done 7 years on the board of the Treasury. And in all those roles, what I'd really learned was you get assailed by multiple requests all the time and multiple issues. And the important thing is, as fast as possible, to identify relatively few priorities. And so, without any knowledge, because I'm not from the health sector at all, then the key issue in the first week for me, and the second week and the third week and the fourth week, was working with, I think, the really brilliant Amanda Pritchard, actually, to work out, so what are the priorities in the NHS about how we can improve delivery. And if you think about the NHS, it was a real lesson that it's not a corporate, it's not a singular organisation which can be sort of instructions come from the top. I know people think that's right, but actually it goes into an ecosystem. And so actually most of the relationships in the NHS are essentially contractual. So take primary care GPs doing brilliant work. Over 90% of health is provided in primary care. But actually the relationship with NHS England is an annual contract negotiation and is contractual, setting all sorts of targets. And if you think about hospitals, 230 trusts, they all have their own boards, and those boards have individual fiduciary responsibilities. So if you think about it, it's actually it's an ecosystem, not a single organization. And above, we have countless new instructions from government. So ministers decide they want to do something new, and those come in multiples, actually. So every week we'll get several new instructions coming from government into the NHS, and we have to decide with government which of those will we actually implement, can they be funded, if we do that, will it displace something else? So there's a huge challenge of multiplicity, and the only way to get through that is to hold to a series of priorities. And then I'll just very quickly say, so at the board, what we think about, we think in two time frames. We think in real-time immediate pressure. So the current pressures on waiting lists, on access, predominantly in primary care, but not just in primary care, and urgent emergency care, which is particularly the issue of winter. And so we think about those and cancer. And then longer term, we have a series of what I call enabling priorities. And if we could simply focus on those and stay steadily, and this is important, stay steadily invested behind them for a period of time rather than chopping and changing to move to something else, we would actually get breakthrough. And over time, actually, the ecosystem would start to change, and actually change quite fundamentally. So the board then focuses on 7 or 8 enabling priorities. An example would be the long-term workforce plan, the first ever long-term workforce plan the NHS has had in its 75-year history, and that was one of the first things that was produced, not in my chairmanship, but nothing to do with me, by Amanda and Julian and Navina and all colleagues around the NHS. So it's a long-winded answer, apologies. But you go back to cricket if you want.
It is interesting because, you know, from the management point of view, what do you do in an organisation where everything is a priority? That's the problem, and you have to be very focused on what your priorities are. And of course now it doesn't help. I mean, you gave a very good example of, you know, politicians come in and they're entitled to do it. They're elected members. They represent the taxpayer. They come in and say, oh, well, actually, today we want to do this. I mean, Wes Streeting has just announced, I think last weekend, that forget the workforce plan, we want more GPs. Well, I mean, okay, let's have loads of GPs, why not? But you just said it's the first workforce plan we've had since God wore short trousers. Battling it through the Treasury was a total nightmare. And I suppose, I mean, what will the Treasury say now about that? Well, I guess they'll say, I'm guessing, you will know, but I'm guessing they'll say, you know what, we don't care what you do. You've got the money, you've got the workforce plan. If you want to buy GPs or you want to buy consultants, it's up to you. That's an operational thing. But actually it's not, because it knocks on what universities do. We've only got 1,300 teaching practices to teach GPs in. You'd have to expand those, and that's not easy. I mean, just that one headline in the newspaper, forget that, we're going to do more GPs, that it's very undermining on the strategic intent of the organisation.
So I'm not sure it's...
I could have phrased that better.
No, but I think the secretary...
I wasn't trying to be contentious, but I mean, it's a bloody...
It's how do you communicate complex problems into an external commentary? And so if you take that example, where Secretary of State is quite right to say, actually, you know what, we do need to increase our GP workforce. And they are doing an absolutely brilliant job. But if I also told you that it's thought that 40% of current GPs will step down or retire or leave in the next 5 years, actually it's really, really important, given that, as I said earlier, over 90% of healthcare is delivered in primary care. It's clearly a major factor. But then to your point, when you think about that increase, well, if 40% are stepping down and the end outcome in 5 years or 10 years' time is only a 5% increase, it's not surprising if actually you first dip down 40% to come up, but you've still got to recruit and train a very significant number of new GPs to counter the departures as well as get the growth you need. And the other complexity actually is not just you've got to talk to the medical schools and you've got to get the GP training practices, as you say 1,300 out of 6,400 primary care practices which are trainers of the GPs. You've got to extend that capacity. But the overall workforce plan has a challenge that Treasury has capped for many, many years, the number of medics trained at 7,000. And I am criticising Treasury on it. I was on the board of the Treasury, so I criticised myself. But actually, putting that cap, it was on the basis that it's better and probably cheaper to buy in talent trained at the cost of another government. And of course, that's very good if you're the only poacher in the pool. But actually, when many nations are now looking for a constrained workforce, actually, it does weaken you very significantly. So the long-term workforce plan, in part, was to say we have to grow not just the medical workforce, the doctors, but also the broader workforce. So we looked at community nurses, we looked at physician associates, and now that's a hot topic. We're looking at physiotherapists, we're looking at technologists. So there's a model which is, it won't be right, but directionally, what should we start to invest in, and how do we get the training pathways going, and how do we get the funding going and persuade Treasury and the Cabinet Office and the Department steadily to invest in those pathways over the next few years to develop that workforce. And that long-term plan is only one of the enabling priorities. And I think candidly, it's an essential priority. It won't be right, it won't be the exact numbers, but they are the enabling steps that allow us to get on the right pathway to deliver the workforce in the shape that we think it needs to be.
Do you think there is much point really in having these long-range plans? I mean, if you look, I mean, this is a conference that's fundamentally interested in technology and the future of technology. I mean, if you look at what we laughingly call AI, artificial intelligence at the moment, it's not really, it's machine learning. We're a long way from AI yet, but, you know, we'll call it AI because everybody does. I mean, there is a huge role in AI in underpinning clinical decisions, in forecasting, and a lot of the things that the NHS has difficulty in doing. And so suddenly let's say, for example, Ali Passer was being interviewed here this morning. A very interesting interview. I don't know if you listened to it, but he has a new product now, a new company, which is effectively decision support. If that comes good, then if you look at physician associates, for example, at the moment, there's a big row between physicians associates and doctors, and the row is really only doctors worried about their future. You could actually underpin physicians associates with AI that really did work, and suddenly the whole face of the workforce changes. Technology is accelerating so quickly that it's really difficult to forecast what we will need in a workforce plan.
Whether that's the right example, I mean, I agree. So going back to this priorities point, there are some long-term views you need to have. So when I arrived, I was quite surprised that we had no target architecture for technology and data across the NHS. And that sounds a bit grandiose, target architecture, but unless you have some ideas of where you're heading, it's hard to make the priority choices when investment is constrained. So if I've got constrained resources, where am I going to prioritize first? And what magnitude of investment do I put into each of those areas? Do I invest hard in primary or secondary or tertiary? Do I invest in finance systems or allocating systems? You know, what do I choose to invest in? Do I invest in cardiac or oncology? So there's lots of pathways that you can go down, but you need a target architecture.
Well, I want you to finish the answer, but I just interject there, and that's the problem for a lot of the guys and girls sitting here. They've all got various products that they hugely believe in, but they've got no front door to knock on and don't know how to sell it.
So I think I often get asked about scaling, and if you were sitting in my shoes or my chair and you came here, I would say to you, now which of these would you scale? It's a huge, huge challenge. But scale isn't actually, I think, getting the product, the innovation, into the whole of the NHS. I mean, partly it's an ecosystem. And I would say you target a particular trust or trusts or an ICB, if you can do that. And then from the centre, what should we think about? Well, I'm going to go back to that target architecture. I think there's a very real opportunity if we can stay steadily invested. I keep using that phrase. We need the investment behind technology, and we need it to be ring-fenced and secured, because otherwise it gets cut away all the time when pressures come from other costs. But we then need to choose at the centre what I would call the motorways, and then leave a portion of budget, available budget, for huge innovation, 1,000 flowers blooming, and let that run. But unless we actually build what I call the spine or the motorways, we've just got a series of amoeba-like innovations going everywhere. It's not quite clear what they lock onto. So we are invested in the NHS app. Now, the app is a front end, but the app really works if it connects to the underlying legacy systems. And if it connects to the legacy systems, it will be an enabler to drive out multiple systems. So if I shared with you that last year, the NHS transferred 44,000 systems onto the cloud. Just think about it, 44,000 systems onto the cloud. Think of the scale of it, think of the multiplicity of it, and that's not all our systems. So the NHS app will work if it connects the systems, that's one. The second is Federated Data Platform, it's Palantir, but it's an ability to get provider hospital data interoperable. And it builds a translation layer across the machine coding of each hospital and allows us to aggregate the data without asking each hospital to rewrite their machine code to actually get to a singular machine code for left knee replacements or right hip replacements or whatever. We will have a translation layer that allows us to pick that up on a national basis and understand the data, and the data will link to cost systems. So FTP is really important. Electronic patient records, really important. Enabling the patient actually to see their records. And then if we can, which is a big ambition, use the NHS number much more broadly. So one of the things that isn't realised, you'll shoot me in a moment or to stop me, but in the financial services industry from which I came, they give their eye teeth for what's called a single customer identifier. Whatever you do with a particular bank or insurance company, that number identifies every time you touch them, every product you have, every time you go to the ATM or whatever it happens to be. Probably don't go to ATMs anymore. So they pick it up. In the UK, the NHS number is the only number we all have. And you get it at birth. There's some argument we should get it actually in the womb, but you get it currently at birth. And you don't get your national insurance number till you're 16 or you start working. So actually the NHS number is a brilliant aggregation point for all your data around your healthcare. So if we can then drive the NHS number as the data aggregation point, and we are in health, now imagine you could then link it to other information that feeds your health condition. So it may be your economic circumstances, it may be other aspects about your lives that tell us about your health. Actually, we start to get real insights. And then the last one I want to focus on is ambient documentation. And you'll know that. That's basically voice to text, and that exists in many other industries. But actually, we've seen in a number of our providers and primary care practices a number of pilots. And if the clinician seeing you as a patient is able simply to diagnose you, talk to you, and it's picked up and translated, and it's machine learning. So actually it produces a much more Hansard-like, succinct diagnosis of whatever the GP thinks is wrong with you or the medic. And we can then load that directly into the underlying systems. We can save up to 30% of a clinician's time. And also, you don't have this thing when you sit with your GP and they're typing away, and then they say, now, how are you? And they type a bit more. They just talk to you and diagnose and advise you, and it just downloads automatically. Now, voice to text, ambient documentation, AI use is really powerful. And lastly, on AI, the NHS uses AI much more than you think it does. It uses it in histology, histopathology, in ophthalmics, in dermatology, in retina scanning, in brain scanning, in X-ray scanning, breast screening. So it is coming in much more than you think it is, and so it should continue. Anyway, I probably rambled rather than answered your question, but...
No, I think it's really interesting for an audience like this, because most of them find the NHS a real jungle and difficult to know quite what the NHS is trying to achieve with technology. There'll be a lot of people here with sort of very discrete products, all of them, many of them very worthy and worth investing in, but how do you get to invest in? I mean, at the moment you're now doing quite a lot of, in fact, talk to us about the virtual wards that you're doing. Hopefully that, they'll dig us out of a bad winter, one hopes. There's a lot more that could be developed with virtual wards. At the moment, the image is your granny fiddling about with an iPad, but it's much more than that.
Yeah, so I'm going to be positive and negative on the virtual wards. My negative is actually, when I arrived in this role, it coincided with an announcement that we were going to roll out between 40,000 and 50,000 virtual ward beds across England.
I remember writing about that. I remember saying, please don't.
Excellent. Well, we didn't, and that's why I'm disappointed. But actually, we've actually stopped at about 12,700, and we stopped actually because the wagons rolled on, and the funding has stopped. But step back to the 3 shifts. So analog to digital, hospitals to community. Less prevention, but it can help on prevention. It fits certainly 2 of those shifts. And I think if you recognise that, it's a brilliant topic to drill into the challenge of the NHS. If you recognise that at the heart of our secondary system, we are massively short bed capacity. Because then...
Just do the beds. We've got, what, 97,000 now?
We've got 97,500 now. In 2003, there were 144,000. In 2010, when the current government last left office, it was 122,000, and now it's 97,000. And at the same time, since the turn of the century, the population of England has grown 15% unaged, and we've become more obese, and more other conditions have arisen. Now, it's absolutely true, we mustn't keep funding acute at the cost of primary and community, but actually at heart of secondary we have a significant bed challenge, and that's partly why, along with social care underfunding, you see complete blocks in our inability to discharge, because you can't get people into the hospital and you can't get people out. But the bed capacity plummeting down at the same time as population grew. Yes, we've done well on length of stay and efficiencies, but we carried on reducing the number of beds when other European countries started reducing the beds, and they stopped and they started to grow them. So virtual wards are really important because they're step up and step down care. And they effectively monitor you as if you were in hospital and you're not in hospital. Your readings get taken 2 or 3 times a day, either Bluetooth, or you have to phone them in, a carer would phone them in, or you would phone them in, and there's a dispatch available of medical resource if your conditions are deteriorating. They help on step up and step down, and you stay in the community. I think that would be a brilliant initiative to stay steadily invested behind, because it would help us hugely. The other thing it moves to is capacity. I do want to make the point about capacity. So at the board, one of the priorities is to think about capacity thematically. That's a bit pompous, doesn't it? But if capacity is beds for the moment, it's not, it's also diagnostics and lots of things, but if it's beds, and you want to think about growing the number of beds, even if there was all the money in the world, and there is not, it takes a long time to build out those beds. So you've got 2 other options, at least 2 other options. One is there a technology solution to that capacity point? And so virtual wards offers that with essentially technological monitoring at home or in nursing homes or care homes of your condition. That's really, really important. The second is, who is using the capacity? And the NHS has a challenge which the private market doesn't have, which is rather like that quote in Gladiator 1. I wouldn't recommend Gladiator 2, by the way, but Gladiator 1 is whatever comes through those gates. So the NHS deals with whatever comes through its gates. It can't choose its markets, it can't choose its patients. So actually we've got to create capacity in the system. And we have currently 25% of the population is over 65. They're 50% of admission, and they're 74. So it's not quite 25, 50, 75. They're 74% of bed occupancy because they tend to stay longer. So if we would proactively manage for their benefit older people, and we avoided elderly admission as far as we were able, we could create capacity within the current system. And if we created capacity in the current system, even though we try and build more, actually we can then start to sequence and then bring other priorities in by freeing up the capacity we have at the moment. So we're thinking very much thematically about capacity. We're thinking about how do we offer a more proactive service to, it's a frailty service. There's a high correlation, frailty to age, but it's an offer effectively for frail people, tends to be elderly. Within that, and then you'll shoot me, 25% of the beds are occupied by people with dementia. And if you think about that, there's a high correlation to age. But the reason proactivity is important is that if, of those 25%, it's not quite half, 45, 46%, are in hospital with a UTI or chest infection. And they're blue lighted in, partly because they're in a care home and the manager, who's not medical, clinical, actually quite rightly says, oh, I'm a bit worried about old Mr. Meddings, he's deteriorating. So they call for help and that individual goes to hospital and is admitted. Now, those conditions don't need to be treated in hospital. It isn't quite the half because there may be other conditions that would bring them in. But even if you could save half of the half of people in bed in hospital with dementia because they went in with an infection they don't need to be treated for in hospital, we could create 7 or 8% more capacity. And that 7 or 8%, it would land unevenly through the country, but actually instead of running at 96, 97%, which we're at the moment in bed occupancy, which is unmanageable, particularly when you get the flood of winter condition, we could get that down to below 90%. And then we'd be getting quite close to the Royal College of Emergency Medicine's safe level of operating, which they believe is about 88% occupancy in hospitals. So thinking thematically about capacity, about utilization, about technology provision can make a real difference to the way the health service operates.
Right, and I think all of that is really very important, and it gives you a clue as to the direction that we want to see technology going in, because technology has a big part to play in that. Now, we have frailty index in primary care. We know who's going to be frail. We know who's likely to need help during a bad winter. We know all of that, but we can't do anything about it because we don't have enough people. I mean, ideally, you want a healthcare assistant or a community nurse to knock on Mr. Medding's door and saying, how are you doing this morning? How do you feel? How are you doing? And you say, fine. You go in the next morning and say, well, I don't know. I don't feel too good this morning. You can see it all coming. But we don't do anything about it, not because of, for any willful reason, not doing anything about it. It's just we don't have the army of health visitors to look after the kids. I mean, the other big user of A&E are children, the under fives. Yeah. It's families and frailty that fill up A&E. And we don't have enough health visitors and we don't have enough community nurses. So shifting and it takes me back to the workforce issue, shifting the workforce to fit what work needs to be done and what work needs to be and can be supported by technology seems to me the direction of travel for the future.
Well, I mean, I would agree with that. I completely agree with that. And I think the other thing is I hugely welcome the 10-year planning exercise. It's important, these 3 shifts. The next question will be, underpinning the 3 shifts, what are the relatively few actions or priorities under each of those shifts you're actually going to implement? That's the key. So what are the vertical struts that support the horizontals, the three shifts in the 10-year plan? So I think it's about relatively few priorities. And I say it again, it's the 3rd time today, forgive me, that you steadily invest behind. And the danger is if you don't, the very significant resources the NHS get scattered. And it's rather like confetti landing on the path. You get no real breakthrough. You have to choose and invest significantly enough behind fewer things to concentrate to get breakthrough. And once you've done that, you can move on. Because the other word for prioritization is queuing. All we're really doing is saying, what should we do first? And then what will come next when that first thing has worked? Right. And for me, that's the big challenge.
Yes, it is. And that's the really important take-home message for anybody here that's working in technology. It's very good to invent something and then go and find a customer for it. The sensible thing to do is to find out what your customers actually want and then provide them with a product for the want. And you don't know what the want is until you know what the direction of travel is.
And can I say, we're running out of time, but I would just like to say, one, I often talk about 4 things when I talk about the NHS. I talk about exponential growth in demand. I talk about undercapacity, be it beds or diagnostics, etc. I then say, today the NHS is providing absolute record levels of healthcare, often missed. We're providing more healthcare today than we've ever done. But I finish with, and this is where you guys are, this conference is really important, the thing that makes me most optimistic is innovation. And the NHS is massively innovative, actually. Now, it's hard to scale, but if you look at what it does with its cytosponges, liquid biopsies, cancer vaccines, we've got to think how that rolls out, mRNA technology, nanorobotics doing cell repair or brain aneurysm repair. It is remarkable. Genomics, you couldn't have conceived what we do today 5-6 years ago. Well, you could have conceived it, you couldn't have delivered it.
The Crick Centre.
So in here...
The Crick Centre.
The Crick Centre.
But go there, blow your mind.
And the NHS, I'm absolutely optimistic, will continue to innovate. It may not pick all of you up, but it will continue to innovate, and we will get better and better and better at delivering what we do. At the moment, the basics are under real pressure. The basics are under pressure because of underinvestment and demand growth and so on.
I think this is the most exciting time for innovators, really, and entrepreneurs in this sector, because there is emerging a clarity about what the NHS actually wants and needs to support it as we go forward. Now, we've got time for 3 questions. I don't want an advert. I'll cut you off. I don't want a polemic. I'll cut you off. I want an interesting question, and I want it in 3 sentences.
Take all 3 in one go.
We'll take all 3 in one go. So, raise your hand, and I'll send my leggy blonde assistant scurrying across.
He can't cut me off. So
oh, sorry. No.
I'd like to say.
Right. There's a hand in the back there. Come on, wake up.
Right,
Otherwise,
okay.
I'll have to find another leggy blonde assistant.
Just like,
there we go. Right.
Well, we'll take all 3.
Oh, okay. Very quick question. So you mentioned that there are key priorities. If we're tracing through strategies and policy, how can we discern what those priorities are?
Okay, hold that thought. How do we know what the priorities are? Next question, there was a lady, another lady's hand went up at the back.
Remember that, right?
Yeah, we'll have it. Yeah. We can do more than one thing at once.
Hi, thank you. Thanks for the interesting information. What I'd like to know is, where does prevention come in this?
Very
What's
good
your
question.
strategy
Thank you.
around
Sit down. That's fine. Okay, prevention. Give her a round of applause because we always forget prevention. And there's another lady here, just down here. Do you remember the first one?
Introduce yourself.
Hi, my name's Olivia. I'm the founder of Remedy.
That's an advert.
He said
You're
introduce
dead.
myself.
Next question.
I'm just
I
doing
warned
as I'm told.
Come on.
So the question is, are you using AI to plan your strategy? And are you involving clinicians, including nurses and healthcare assistants,
Okay, fine.
in your
Thank you. That's it.
decision-making?
Good. We got it. Right. Sorry to cut you short, but if I don't finish on time, I'll lose my bonus. Right. Over to you.
So
You remember what they were?
yeah, I'll take them in. I'll take them in reverse order. So the answer is sort of yes on are we using AI to help on our strategy. So
AI doesn't exist. We've got machine learning. We won't have AI for another 20 years.
but we are using AI or machine learning. We are using those if we look at things like in our strategy we look at health, the contribution of health to economics, to the economy, and we're using large data essentially to understand population health and how it's impacted across the workforce, and that's work alongside
It's
Treasury.
worth adding, a third of senior managers in the NHS are clinicians as well.
I think it's over 90%.
Is it really?
Yeah, Amanda Pritchard would tell me that
I
over
suppose it's
90.
how high up you go. Yeah, but there are a lot of clinicians who are involved in management.
So we are
They're
using.
very good.
We use clinicians. No, we are. So we bring people from all over the systems, primary care, and they come and they help us work on strategy. So the Fuller stock take, Claire Fuller was a practicing GP, Amanda Doyle was a practicing GP in Blackpool. She now runs primary care for us. Yeah, absolutely. So Daniel Elkalez coming from the London Ambulance Service. So lots of people.
And the GIRFT program. I don't know if you know about the GIRFT program, Getting It Right First Time. GIRFT program is a fund of really excellent stuff. It's all clinicians. Have a look at the GIRFT program.
On prevention, I'm sorry if I didn't mention it, and that's a real omission, so I apologise. It's absolutely vital. It's absolutely vital. One of the things we need to recognise, and Aradazi, who was on our board for many, many years, till a couple of years ago, and produced that very good narrative about the current state of the NHS. One of the things he points out is that society is much sicker today than it was. And one of the things for the NHS, it goes to, of course, prevention matters hugely. Many of the things which are causing ill health lie outside our sort of human condition. They are, we deal with whatever comes through those gates, but what's coming through those gates is actually the ill health is created by many other things. We've just opened our 30th centre for severely obese under 6-year-old children, 30th. We've just opened our 15th gambling addiction centre. So the NHS is having to deal with society's shape, and prevention therefore absolutely matters. Now I'm going to say something stupid again. I've been attacked for it before. I'm going to sound politically very naive, but I would say bring on the nanny state. I'm really sorry. I think that whether it's minimum alcohol pricing, whether we explore what Australia is doing on social media for under 16s, whether it's actually legislating against fats and sugars, not sugar, you know, there's so much we should do to enable the society to be fitter. And if I was Wes, and he does believe in this, I would try and make the UK the fittest, healthiest nation in, say, Europe, where he wants to pitch it, in, say, 10 years' time. But that requires action from government into the way society actually behaves. Why have we got fast food outlets outside primary schools? And there's so much we could do which would actually help society to be better. On strategy,
before you do, there's a fantastic new book on prevention. It's called Wellness. Modesty prevents me from telling you who wrote it, but you can get a free copy if you find. If you shut up.
It is actually very good.
I thought you said no plugs.
You could get a free copy here today if you find me on the Academy of Fabulous Stuff stand. Right, and the
last thing on strategy. So it's a really good question, and one of my answers is we need to now wait for the 10-year health plan, which is in process. And there's lots of public deliberative events, and there's a very good team which is going to synthesize lots of the underlying recommendations. It's both top-down and bottom-up. And that will produce a series of core strategic directions. In the meantime, and what I said to the Secretary of State, and Amanda says actually, is what the NHS England board is focused on, and our responsibility is delivery. We're focused on long-term workforce plan, long-term capital plan. We debureaucratise the centre. We've taken out 35% of head office staff. We're focused on technology, both in architecture and in relatively few, I'll call them motorway implementations. So not everything, but what are the key components of a technology system? We're focused on capacity, as I talked about thematically, and then we're focused on embedding innovation. Innovation predominantly in medtech, pharmaceuticals, genomics, and then the last two are pilots. One is frailty, which loops back into thematic capacity, and one is around, is there a new model needed for primary care? Not because they're doing a brilliant job, but just because of the pressures on primary care, how do we think about a new model? The current contract with GPs is 1,000 pages long. 1,000 pages long. So it is hugely bureaucratic and too many targets. So those would be what the NHS England board is focused on. I think they're a good set of priorities, actually.
Good. Now, you're leaving in March?
End of March, yeah.
End of March, your time is up?
It is.
Okay, we've got about 90 seconds, I think, before we have to get out of here. NHS 5 years from now.
So I'm optimistic. I really am optimistic, actually. I think the current narrative is slightly too difficult. I think we're being overwhelmed, and that's a different challenge from the narrative that is often put out there. It's still a big, it's still a big
capacity issue.
Well, I think you've got to fix the basics.
Yeah.
At the same time as enabling the transformational change. And at the moment, the basics, particularly in winter when ambulances are queuing outside, we can't get people out, overwhelms people's views about what the NHS provides. And actually, most people, the vast majority of people, when they get into the NHS, get brilliant service, actually, and they get looked after. And as a small point, the reason I took the job is I think one of the best things that Britain has ever done, best things philosophically, is the idea of a health system accessible to all, free at the point of delivery. It's such a brilliant cultural cement for any society, certainly one that I want to live in. So fixing the basics, will we be there in 5 years' time? I think we'll be better. I think a parallel track actually will be some of these pathways of transformation, we will be a long way down. I just hope that we stay on relatively few till we get enough breakthrough before we shift on to one of the other many, many things that our masters and mistresses are often asking us to change to. And they're under too many pressures as well.
Actually, that's just quickly, I mean, that is a very interesting point because technology, this is basically a technology conference. Technology is the use of technology is overtaking the NHS. I read somewhere that 14% of people now have a private GP. 14%. Fundamentally, that's mainly a GP on their phone. They're doing the subscription type thing. It's so the people are. In a sense, it's the NHS having to catch up with people's expectations and the use of technology, and it's finding the safe pathway.
So one thing I would guarantee you, that's a big word. It's a big word, isn't it? Is the NHS app is absolutely revolutionary. And I think if we stay in...
Who's got the app on their phone? Put your hand up. It's fantastic what it does, I think. And it just suddenly appeared overnight during COVID, really.
And think what more it might create. And then use the genomics example I talked about. and think if we can do the same with technology. So last year we did 800,000 genomic tests, whole genome, panel and single tests. We now scan for 200 cancers, 7,000 rare diseases. We're now doing a newborn generation study. We're building a national genomics research library. We're building a unified genomics record for each citizen who comes. Now, that's using real data. That's using real technology. That's using real medical innovation. So we've got to continue to fix the basics. Will we be quite there in 5 years' time? I don't know. The stresses on finance and capacity and capital are pretty tough, but I do think the parallel track of innovation coming actually gives me real confidence that actually the NHS will be in a much better place. It's in a good place today. We're dealing with lots of demand. It's under pressure. It will still be under pressure. I don't think we'll ever keep up. No, we'll keep up. I don't think we'll ever catch up, because medical science is brilliant and innovates ahead of us. But can we get to a point where we fix the basics and then we continue to keep up with that new trajectory? But we've got to fix the basics first. So thank you very much.
Well, thank you. An optimistic end. Richard, we wish you all the best in whatever it is you're going to do next. And thank you all for coming. Merry Christmas, and don't give up.
Thank you so much, guys. That was amazing. I was feeling a bit down when I came out here with all the workload and everything and the workforce crisis, but now I've got a slightly warm, fuzzy feeling inside me. Right, so when the next session is going to be some of our brightest and best talent who are going to share some of the challenges that they have and how they've overcome things. So if I ask these organisations to come make their way to the front.